right. Assalamu alaikum, everybody. So today we have Dr. Arif Khan at Brown Bear and at Bases. We're going to introduce him first. My name is Dr. Jawahar Alvi. I'm a BCBA, and I am so excited and so thrilled that today we have Dr. Arif Khan, who's going to be here, and we are going to introduce him first, which is he's one of the best pediatric neurologists that I have worked with in Dubai. He is a British board-certified consultant pediatric neurologist. After having completed his general pediatric training in UK, he got trained as a senior registrar in 3 major tertiary university hospitals, including the Royal Manchester Children's Hospital, University Hospitals of Lancaster, and Queen's Medical Centre, Nottingham. He was awarded the completion of certified training in pediatric neurology by the Royal College of Pediatrics and Child Health following, which he took up his consultant pediatric neurologist role in the University Hospital of Leicester. At University Hospitals of Leicester, he was the lead clinician for complex epilepsies, vagal nerve stimulation, and ketogenic diet in the region. After that, he moved to the Middle East in 2015. He was appointed as the head of children's services at the American Center for Psychiatric and Neurology. He helped develop a children's neuroscience team at American Center and worked as a pediatric neurologist in Abu Dhabi and Dubai. After having completed his contractual period with the American Center in 2017, he joined MedClinic City Hospital in Dubai and the Royal NMC Hospital in Abu Dhabi. He currently continues to provide his services and expertise to these institutions. Dr. Arif Khan is an avid writer, authoring more than 40 peer-reviewed and public health publications. He has been conducted presentations in various academic seminars and conferences. He has an extensive experience, and right now he is the initiator of Neuropedia, and currently they have 3 settings in Dubai. So welcome, Dr. Arif. Thank you so much for taking the time. Please tell us a little bit about yourself.
Okay, Assalamu alaikum. So, Dr. Arif, I will keep it simple. So, I am a children's brain doctor and trained in the UK, settled in Dubai, actually brought up in Dubai, and then away from Dubai for about 20 years, and then came back to Dubai 10 years ago. I don't want to give away my age, but been in Dubai for the last 10 years. And I developed and founded the first children's neuroscience center here in Dubai called Neuropedia. And for the last 10 years, we've grown into 4 branches now, which are under a brand called Neuropedia and Kids Neuro Clinic. And we're spread across Dubai and Sharjah. I also provide services in a very specialized area for gene therapy for children in Fakir University Hospital in Dubai. If you want to read about what I do and keep up to date, I have a website called drarifkhan.com. And that would give you an insight more into what I do. But I'm a children's brain doctor. I do a lot of awareness. I have 2 YouTube channels. I'm sure Ms. Jawahar will share those links with you. But that's mainly for awareness. And I reach out to adults and parents and teachers just to talk about neuroscience through those YouTube channels. So yeah, that's how I've got 3 kids, 1 wife, and Dubai has been really kind over the last 10 years. That's all I can say.
Thank you so much. I have actually gathered some questions over the years talking to parents because, as you know, we have bases in Pakistan and then we have Brown Bear here. So they have a lot of questions, and I'm just going to ask you those questions. If you'll be so generous to answer those for us. The first question is that if a child's sleep is severely disturbed, what neurological causes should we rule out first?
Excellent question. It's very commonly asked by my parents that come and see me. The context is important. So if you're talking about children with autism, I'm assuming that now we're talking about children with autism. 80 to 85% of children with autism have sleep problems. So either they have a sleep initiation problem or sleep maintenance problem, or sometimes both. And sometimes it can be kind of devastating in managing these conditions because no matter what you do, things don't change. So yes, autism children have diurnal sleep problems. Sleeping is a big issue, initiating and maintaining. But there are some things you have to rule out. If your child is not sleeping well, or waking up intermittently, or not going to sleep, there are a few things you have to rule out. One, if they're waking up in the middle of the night, things like epilepsy, things like headaches, sleep apnea. They might have enlarged tonsils and adenoids, and their airway is getting blocked, and they keep waking up in the middle of the night. They're on bed, but they keep waking up, and parents think, oh, my child has woken up, slept the whole night, and still not able to function in the morning. How? That's because their sleep quality is poor. So, getting an ENT to see them and do a sleep study is important. So, these are medical conditions that can disrupt your sleep. But generally, most of the kids have what is known as behavioral insomnia. That means they don't want to fall asleep at night and their whole sleep clock has shifted. That's where you need a neurologist and a sleep therapist, as we call them, to get involved. And there are techniques to change that behavioral patterns. There are medications we use sometimes as adjuncts to support changing time. For example, we use melatonin to help shift the clock back, but melatonin is a supplement. It's used for a short period of time. Sometimes we use other medications, which obviously I can't discuss it here because it'll go. I'll be only talking about sleep here then.
Mhm.
Yeah.
Thank you so much. Which neurological symptoms can be worsened by any kind of gastrointestinal dysfunction, or which symptoms do you think typically improve when gut health improves? I know these are different, topics, but do you think that gut health is kind of related to neurological symptoms?
Whether it's related, yes. So we now know that there is what is known as gut-brain axis,
Mhm.
a connection between the gut and brain. When we say a gut instinct, I had a gut instinct.
Yeah.
There's a reason for it because your gut talks to your brain all the time, and your brain talks to your gut in response. They are two good friends. They talk to each other. So, but on the other hand, recently there have been a lot of talks about microbiome and the kind of bacteria we have within the gut that influences the symptoms of autism. Now, that is open to discussion, open to debate, and there are parties on both sides. But generally, most of the kids with autism have some gastrointestinal problems. Either they have constipation, they
Mhm.
might have persistent chronic diarrhea, they might have reflux, which is very often. And when you have this persistent symptoms, your general demeanor would be of one who's very frustrated, angry, and in pain. So if you have these symptoms in your child who has autism, try and fix them first. Just simple management of constipation, for example, changes the child's behavior. If a child has reflux, if you suppress the reflux, the child becomes more happier, sleeps better as well. So, yes, they have a connection, but you cannot blame the gut entirely for as a causative thing for autism.
Mm.
No. But yes, you need to get those symptoms better by focusing on the gut if you're managing a child on the spectrum.
Thank you. What baseline and follow-up tests should be conducted before or after starting antipsychotic or anti-seizure medications?
Two different questions, Jawahar. The antipsychotic, usually, I just do a liver function test. I make sure the parents are aware of the possible side effects to look out for, like weight gain. In some, their appetite goes up. In some, it's about significant sedation. So
Mm-hmm.
that's why we always use it at night first and then introduce the morning dose. And do I do bloods on them or as a regular monitoring? Yes, every year once I check their liver functions, their prolactin level, which is very important to check. With anti-epileptics, it's a different story because anti-epileptics, you have a choice of 30 different anti-epileptic medication. So it depends which one you're using. So if I take a common one like, say, sodium valproate, which is called Depakin in Dubai, the brand name, we always monitor their liver function test and we tell parents watch out for weight and control the quality of food that they eat. Sometimes it can cause increased weight gain in kids. And so we monitor that and the liver function test. For example, and the other one is levetiracetam or Keppra, as it's called in Dubai. It
Yeah.
doesn't have any systemic side effects, but it can cause problems with agitation, aggression, hyperactivity. So in a child who's already having ADHD, I tend to not use that medication and use the other one. So it depends which medication we're talking about. Your neurologist will be the best person to guide you as to what needs to be monitored.
Okay, one question off book. Do you think that it is important that a psych and a neurologist should work together if a child needs medication? they should be
Uh,
collaborating together, like in terms of if there are behaviors in a kid and seizures, they should be collaborating, right?
Absolutely,
Because there's a
absolutely.
myth that no, the neurologist can handle the antipsychotic the medication, or no, the psychiatrist can just handle the seizure medicine.
The psychiatrists usually don't monitor seizures because they are not trained to manage EEGs and brain electrical activity. They don't do that. That's not our scope of work. They manage the psychotic medications and the psychotic symptoms. Neurologists, on the other hand, are trained to manage epilepsy and
Okay.
seizures. So they should be the only ones who manage epilepsy for a child. Now, some neurologists have a behavioral background also, so they can manage the antipsychotic medication sometimes. But once it goes, say, beyond the first line or second line, we normally refer them to the psychiatrist for help.
Okay.
But
Yeah.
they should work together. Yes, you're right. If a child has both, they
Yeah.
should work together.
Okay. So which medications or combinations should be avoided to prevent adverse reactions when antipsychotics or seizure medications are already being used?
There are many. I mean, depends which medication. So, for example, if there are enzyme inducers, we should not use too many enzyme inducers together. We should, if I'm giving something that a child puts on weight with, like sodium valproate, for example, for epilepsy, if I give risperidone or aripiprazole on top of it, the child is going to put on a lot of weight.
Okay.
And that should, if a medication is causing sedation, like an anti-epileptic medication that causes sedation, and on top of that I add something like an aripiprazole, I'm increasing the sedation. So it's case by case basis.
Mhm.
Some contraindications are very strong. Like, for example, if I'm using something like a Keppra or sodium or levetiracetam, which causes severe aggression in some kids, causes hyperactivity in some kids, and the
Mhm.
child already has ADHD, then we should stay away from it and try something else.
Okay.
But every case is different, Jawahar. We cannot have a generic this thing on that. Yeah.
Sure. Should all kids with autism go and see a neurologist?
Um, See, there are some neurologists who are trained in neurobehavioral science.
Mhm.
I do autism management. I start from diagnosis with the help of my team, my psychologist and speech therapist and OT. We do diagnosis and we do interventions and treatments. But not all neurologists manage autism because they don't want to. They have fixated in, say, epilepsy or neuromuscular conditions and so forth. So it depends who the clinician is. Can neurologists manage autism? Yes, if they have a neurobehavioral background. But whom would you, if you go to a child psychiatrist, for example, would they manage autism? Of course they would, because that's their primary role.
Okay.
Would Then psychologists are there who support in diagnosis as well. So your diagnosis is not made by a single individual, but a team of professionals working with your child. So in Dubai, in Neuropedia, we have me as a neurologist, I have a psychologist, a psychiatrist, a speech OT, and a BCBA, and a psychologist working together to give the right diagnosis and right behavioral interventions to that child.
Okay. Are there specific brain regions in the autistic children that may be overactive, underactive, or poorly connected? And how can they be assessed, when you guys are doing those imaging
Yeah.
for the kids?
So autism diagnosis does not require any imaging for that matter. So when we see a child with autism, it's purely a neurobehavioral assessment. It's purely criteria-based assessment, and we do something called as ADOS. I'm sure you're familiar with that, which is what we use as a gold standard here. Now, kids who have other issues, like if they have dysmorphic features or they have significant regression, and we are suspecting a neurometabolic condition or a genetic condition, then we do the MRI scans and biochemical testing and genetic testing and so forth.
Okay.
Now, the answer to your first question, which areas? So there have been a lot of studies, but still we don't know, because we know that autism is not a single factorial disorder. It's not about saying, okay, it's genetic or it's environmental. It's a mix of both.
Mhm.
Now we have included epigenetics into it as well, so it becomes even more complex. So if I do an MRI on, say, 100 kids with autism, what are the two areas of interest? One is something called as amygdala.
Mhm.
Amygdala is deep inside, which is our emotional brain or social brain, as we call it, and also the medial part of the frontal cortex. And that is where those two highlights we get when we keep doing MRIs on kids under a research paradigm. So these are the two areas of interest, and these two areas help you to socialize better, to control your sensory needs. And we know that these areas are ones that are affected because one, the MRI, multiple MRIs have shown that, and two, because the symptoms match the functions of those areas.
Mm, okay.
Yeah.
How long should an EEG be performed to reliably rule out seizures, especially subtle or intermittent ones?
So in adults, they do 20 minutes EEG, awake EEG for 20 or 30 minutes. But in children, we try and make a point to make sure we do both awake and sleep EEG. So our total EEG duration lasts anywhere between 40 minutes to 1 hour because we include sleep as well.
Okay.
Occasionally, we need a child to undergo a 24-hour EEG or an overnight EEG, but that's rare as compared to the regular short EEGs that we do.
Okay. To what extent do sedatives affect EEG results? Should we avoid them before the test? What can be done in case of aggressive and hyperactive kids?
Yeah. So yes, we do give them medications, but because they will not allow you to put EEG leads on your head. But we have to be careful because deep sedation, either with things like benzodiazepines, diazepam, and much deeper anesthetic drugs, can just hamper the EEG completely. It can make it flat. It'll just abolish the background. So there's no point doing the EEG in the first place. So we use the milder ones, which have been tried and tested. Like sometimes we use melatonin to help them sleep. Sometimes we use something called clonidine
Mhm.
to help, or at times something called chloral hydrate, which we know doesn't cause significant changes on the EEG pattern, so you can read them well.
Okay. Okay, now I'm going to ask you a question. What are your views on cerebral folate deficiency and which supportive supplements are recommended alongside leucovorin if needed? Because leucovorin is the new, medicine that is being prescribed for autism. And I've seen some kids, I've seen good results who had the deficiency, but the kids that didn't get tested, they didn't have such good results.
So, firstly, I would like to thank Trump for coming up with this a couple of months ago. It has made my life a nightmare. So I've had close to 160, 170 inquiries in the last 2 months. So what I've done is I made a video of this and put it on my channel called Second Opinion. It's
Sure,
just a 5 minutes video. So please, whoever, I might not be able to give you a complete answer on
sure,
this podcast, but go and listen to that.
I will.
So leucovorin, we knew about leucovorin for more than 12 years.
Yes,
So Trump hasn't introduced that. We know about it.
yes.
Now, after it became political and it came out, it reached a point where people just wanted to rush and jump into the bandwagon and try to find out what's going on. So many of them approached me in Dubai as well. So let me explain to you what it is. So leucovorin is a folinic acid, right? Now let's go back and look at this. So brain needs folate, and that's why even pregnant mothers we give them folate when they're pregnant, so that the risk of neural tube defects and neurological defects can be minimized. Now, and there are some kids who have receptors in their brain which does not allow folate from the body to get into the brain. There are
Mhm.
some receptors inherently, and that it doesn't allow the folate to get into the brain. So the brain is not getting folate, the brain is not growing. How do we reach that diagnosis? Okay, so first thing, if I take 100 kids with autism and I do something called as folate receptor antibody test or FRAT test,
Mhm.
about 40 to 50% of them will be positive.
Okay.
Now, that doesn't mean they have cerebral folate deficiency and they should be given leucovorin. No, it's just a screening tool. It'll pick up the ones that are prone to have the folate deficiency. Once we do that blood test and we find out, okay, out of this 100, these 40 have the FRAT positive test, they need to have something called as 5-MTHF testing or folate testing in the CSF, which is the water surrounding the brain. And this is done by lumbar puncture. It's like what we do when a child is suspected to have meningitis, a lumbar puncture, a needle going in the back, and the fluid around the brain is tested.
It's painful. I mean,
No, it's a straightforward case. It can be
okay.
done under sedation, anesthesia, or in a small baby just by restraining the baby a little bit.
Okay.
So it's like a blood test, but it sounds horrible because you're taking the water from the back, but it's pretty straightforward. Now, if that comes positive, then you can confirm the diagnosis of CFD, cerebral folate deficiency. And in those children, high dose leucovorin could be beneficial in improving the vocabulary of a child and the speech ability of a child. Not so much with the behavior, but speech. Now,
Okay.
it's very clear that the studies have shown us that it might be, this is also is very likely, it's not a confirmed statement. But if you have a CFD child, then yes, give them leucovorin at a high dose, at a prescribed dose, and you will expect some changes in their speech acquisition. What's happening now is that either parents are jumping onto e-commerce, platforms and buying them online and giving them at low doses or very high doses,
Mm.
or doctors are just doing the FRAT test, which is the blood test, and then putting them on leucovorin,
Okay.
and or they're just lost. They don't know what to do.
Mhm.
So my recommendation for this is always, if you are going on that path, and if you have a young child who's nonverbal, and if you want to explore whether your child has uh, folate deficiency or CFD, go through the process of the assessment, which is FRAT test followed by lumbar puncture, and then confirm it. Once you confirm it, then you start on a proper dose of leucovorin under a doctor's guidance.
Thank you. Thank you so much, because this is not happening as it should be. All right. Um, is there any effective approach to treating autoimmune encephalopathy in later stages of life?
Yes. Autoimmune encephalopathy. Okay. So let me give you a backdrop of this. So in the 70s and 80s, there were many children and adults who used to come to a neurologist with sudden change in behavior. They will have amnesia, they'll lose their memory, they will start acting differently, sometimes a maniacal presentation, psychotic presentation. And many of them used to be taken to religious leaders to take that, things out of them, and it was a chaos. Autoimmune encephalopathy was not known then because we couldn't test for autoimmune or antibodies in the blood then. Over time, these psychotic conditions, psychiatric conditions, loss of memory, and epileptic seizures that they used to present with, the fraternity started studying about it, and we realized that there's an entity called autoimmune encephalopathy, which is you have a viral infection or any infection, your body produces antibodies against it to fight that infection. But by an error, those antibodies start fighting your own brain.
Mhm.
That's why it's called autoimmune. So once it starts fighting your brain starts having pathological changes, whether it might be in the white matter or the gray matter outside, and those symptoms come up. So now when we suspect an autoimmune disorder in a child, we do an MRI. Of course, there might be some changes. We do a lumbar puncture, and we can pick up those antibodies in not all, but most cases. So for example, there is anti-MOG antibodies, VGKC. There are nice, wonderful names to them, NMDAR. So we test for those antibodies, and if it's positive, we start them on high-dose steroids, or we move to IV immunoglobulin or plasmapheresis. There's a clear consensus on how we approach treatment in these kids. But many of these children, they get better and they go away, but this can recur. It can happen again after a few years. And then the treatment has to be adjusted accordingly. So it is a known entity, it's treatable, and in the right hands, you can manage that really well.
Okay. All right. Okay, just a few more.
Yeah, go on.
Okay. What neurological conditions are associated with dysgraphia, dyscalculia, and dyslexia, and how do we differentiate between motor dysgraphia and language-based dysgraphia?
Okay, so
Or we can
as we
just
know,
say
yeah.
dysgraphia, that, how would you
Okay,
differentiate?
so dysgraphia is about, you're talking about the handwriting
Yeah.
mainly and children not able to write properly as such. Um, the first thing I do as a neurologist when I see a child with dysgraphia is rule out any mechanical problem.
Mhm.
So, does the child have a problem with a neuropathy or joints or the bones? And that's why the child can't write. So, that my clinical examination plus or minus some neurological testing can rule that out. So, once your hand function is normal, there are no tremors, coordination is fine, then you can start looking at the inherent software. So, our coordination, all of us are not the same. So I can ride a bike in a slightly better balance than someone else. The
Mhm.
other person might be able to walk on a tight rope better than me. So we all have a different level of coordination.
Mhm.
And you need to have the wiring connected in your brain to develop writing in children, for example. So it is with practice that you develop writing, right? And that part of my brain should function well, the cerebellar part, for example, to connect that brain to my hand and so I can write properly. Unfortunately, some kids are born with that misconnection or inability to get that part of the brain functioning properly. For that, neurological testings are not going to help. We cannot give them medication to change it. We have to accept that the child has that deficit. What can help the child is building new wires because we have neuroplasticity in us. Our brain regenerates areas or reassigns role to other areas of the brain. That's the beauty of the brain. And we have to use that neuroplasticity to train the child to start writing better. And that's why children with dysgraphia go to occupational therapists to help support their writing, for example.
Okay.
But I cannot do any special test to tell you what area of the brain is affected because the MRIs will be normal in most of these kids.
Okay. Okay.
And kids who have dysgraphia are likely to have things like dyscalculia as well. Not all of them, but some of them. So we have to make sure that this is purely a software problem rather than an organic or neurological problem, and other systems of the body are unaffected.
Okay. Okay. Thank you. If a child is not progressing or regresses, often what neurological causes can be ruled out immediately? It happens often in case of PANS and PANDAS. I would like to know how neurologists cater regression in autism.
Yeah. So regression is a huge topic, Jawahar. I mean, for regression, there are more than 100 causes. And the common ones, for example, a child who's extremely well has a viral infection and then suddenly goes downhill, and or bacterial infection and then suddenly goes downhill, loses his skills, starts having seizures. Yes, pandas or PANS is a concept that has been thrown around, and they get steroids and autoimmune IVIGs to help treat that. But that's extremely rare, those cases. The common regression ones are, number one is autistic regression. So we
Okay.
see kids who are 18 months old who are absolutely fine, saying some words, and they suddenly lose their speaking skills. They lose their ability to socialize. That is, we know that 30% of children who have autism have regressive autism.
Mm-hmm.
So why that happens at 18 months, we don't know. But we have seen a cluster of kids within autism who have regression. So those are the kids falling under the regressive category. And those children are the ones we consider as aggressive treatment. We do things like EEG, brainwave test to make sure there is no epileptic reason for it.
Okay.
There is the second group of kids who start regressing later on, like 3 years, 4 years. And those are the ones we have to look for neurometabolic conditions, where we have to do extensive testing, whether it's blood test, genetic test, and EEGs and MRIs to see if there is any neurological reason for their regression, like neurometabolic. You have heard of Batten's disease, where they lose their eyesight, they suddenly start losing their cognitive skills, and they have seizures and they go downhill. Or Sanfilippo's. There's a list, huge list of them. But autism is one of them, where you have regression later on, 18 months to 2 years. But beyond that, yes, a neurologist is involved if you have a regression in a child. But most cases are not pandas or PANS. They have a huge other list of neurometabolic conditions. Yeah.
Okay. The last question is, what is the effect of the use of long-term melatonin on the brain? Can it trigger seizures?
Okay, so melatonin use cannot trigger seizures.
Okay.
Okay, long-term use, I have used it in children for children with cerebral palsy, severe neurodegenerative condition. Children with autism have used it for 5 years, 6 years, absolutely safely without any issues. The long-term problems with melatonin now, it's resurfacing. There are some articles being written about cognitive abilities, then a dependence on melatonin later on, but it's not been proven yet. So even currently, if you look at the American Academy of Pediatrics, even and their recommendation, melatonin can be used as a sleep instigating or sleep initiating drug or supplement for children who have behavioral insomnia. So I think it's very safe to use it. Even if a child is using it for 3 years, 4 years, it's okay. I'm not saying they have to. You always have to think about withdrawing it. But if the child needs it, then yes, up to 3 or 4 years is absolutely fine.
Okay. So now before we end, I would, because this podcast is going to be seen by parents in Pakistan as well as parents in Chicago, and I mean everywhere. So my question is that, parents from Pakistan, they can definitely come to Dubai, no issue. They can come consult with you. Parents from Chicago will ask me, how can we consult with you? So probably would there be a possibility of online consultations?
Uh, Online is always difficult because see, for example, me as a neurologist, I need to look at
Yeah,
the MRI. There's
yeah,
so many things, and the child's examination is very important.
right,
In an area like autism, I can get the documents, I can analyze the documents, but being with the child and analyzing the child in my clinic is, there's no substitute for it. So I can do a virtual call with a parent through one of our clinics, and we have a system by which we have teleconsultation.
sure.
But I'm not sure whether I'll be able to offer anything else to that parent.
Maybe if they would like to do a second opinion with an MRI or an EEG, that would be a possibility.
Yeah, that's absolutely fine. I mean, they'll have to send the documents in advance before we sit on a call because the call will be for 20 minutes or 30 minutes. I'll have prepared everything before that to talk to them about it. So we can probably add the numbers if you want in your
Sure.
to con for letting them contact one of our centers. Yeah.
So if you could, after we end today's podcast, if you could send your contact information and how to get appointments with you, we would appreciate that. And then I could just let all the parents know that they would have to, if they're coming to see you physically, that is different. But if they would like, telehealth, then they would have to provide the documents beforehand.
Yeah.
All right.
I would just say, I think the two channels I'll be sharing on your podcast, obviously the parents would see that. I would urge them to subscribe to that channel because we are trying to create some really good content in there, not just for kids, but for parents themselves, and share it with as many parents that you know. That's my
So
request.
yeah, and I will also put the link to those channels under this podcast so that they can subscribe to those. So I really appreciate your time today. Thank you so much. It was really good to see you again. Thank you
Thank
so
you, Jawahar. Pleasure as always,
much.
and
Okay.
looking forward to hosting you in Dubai on your next trip.
Oh yeah, definitely. Take care. Have a
Yeah.
wonderful day.
Take care.
Bye-bye. Bye.
Bye bye.